Hello everyone and welcome back to a new session of clinical pharmacology. Today we are going to speak about sedative hypnotics and anxiolytics as a part of central nervous system clinical pharmacology. We are going to discuss the anxiety, normal activity of central nervous system. We are going to speak about the meaning or the medication that produce sedative effect, medication that produce hypnotic effect, or the medication that produce the general anesthesia, maybe moving to the effect of the medication on the brain in general. When you increase the dose of this medication may produce coma, and some of this medication may carry the risk of respiratory and cardiovascular suppression. We are going to speak about three main group of sedative, hypnotic, anxiolytic. The first group of medication we have benzodiazepine. The second group we have barbiturate. Then we have other group of medication will be covered. We are going to speak about what is a first line therapy or medication for anxiety. Again, we are going to discuss them individual drugs in each group. For example, for benzodiazepine we have list of medication. For barbiturate we have list of medication. We are going to discuss the mechanism of action of these medications, how this medication work. Is there any risk factors from the or side effect warning, precaution, or contraindication from these medication. Okay, as we mentioned, our topic for today, sedative, hypnotic, anxiolytic drugs. As introduction to our topics, we have the simple definition for anxiety. Anxiety may be considered as an unpleasant state of tension, apprehension, like general anxiety disorder, or uneasiness, like fear races from unknown source like phobia, or unknown source like panic, for example. So we are going to discuss like general anxiety, phobia, panic attacks, all these cases here, and what type of medication we are going to use. Here they try to remind us that patients suffer from anxiety in general, phobia, panic. The patient may present symptoms related to the activation of central nervous system. Here, this one here stands for the central nervous system activation. Okay, this one stands for central nervous system activation. If you activate central nervous system, the patient will suffer from tachycardia, sweating, trembling, and palpitation. The situation here we are going to face, or are going to see patients suffer from mild anxiety or like severe anxiety, depends on the situation. So if you have patients suffer from mild anxiety, this is a common life experience and does not require treatment. So when someone maybe prepare for the interview or for the exam or something else, maybe the individual suffer from mild anxiety. This does not warrant the treatment for this case. It is very important to have a little bit of tension, anxiety, in order to prepare yourself, your nerves, your central nervous system for the challenge you are going to face. But if you have some individuals, some patients are from severe, chronic, and debilitating anxiety, that will affect our life activity. This may necessitate the treatment with anti-anxiety medication or psychotherapy treatment. Okay, so as you can see here, we are speaking about the normal person here. Okay, so in the green square here, as you can see it here, the normal person, maybe the situation for the normal person, we have normal central nervous system activity. So you can see the normal activity for the brain, the spinal cord, the activity will be normal, and the person will behave like with a normal attitude and behavior, knowledge, everything. But what happened if this activity increase? If you have increased activity of the central nervous system, the situation may lead to the anxiety. So here we need to maybe interfere with some medication if this anxiety severe, chronic, and affect the patient life. But like as we mentioned in the slide before, if you have mild anxiety does not warrant the treatment. Okay, moving to the next. So we can see here we are talking about the activity, increased activity. What happened if the activity decrease in the brain? So if the brain activity decreases, you can see the patient will maybe goes into the sedative effect. So we have some medication inhibit central nervous system and lead to the sedative effect. And sedative effect located between hypnosis, between sleep, and between the normal person behavior, normal person central nervous system function. So we have the sedative effect. So the sedative effect, we have some medication produce the sedation. If you increase the inhibition of the central nervous system, you can see here the arrow here represent the inhibition of central nervous system here. If you increase the inhibition of central nervous system with the two arrow, you can see it here like more inhibition of the nervous system here. Okay, so the situation will be induced sleepiness or hypnosis or hypnotic effect. So you maybe produce the hypnotic effect for the patient. Here we are talking about phenobarbital or diazepam, for example. If this medication produce more inhibitory effect with the three arrow here, and we can speak about this one like 3 minus here inhibitory effect, 2 minus inhibitory effect, or 1 minus inhibitory effect. So when you have 3 minus inhibitory effect to the central nervous system, this will lead to the general anesthesia here. So the situation will be general anesthesia. So again, this is could be like dose related for some medication. For example, if you prescribe if you have patients suffer from anxiety and you prescribe diazepam IV for example to the patient, you are going to release the anxiety with a small dose. If you increase the dose, you are going to bring the patient to the normal behavior. So with the small dose here, we are talking about small dose. Okay, the small dose will reduce the anxiety to the normal behavior. If you give the therapeutic dose, this will be maybe affect the bring you the maybe the desired effect. If you increase the dose a little bit more, this will produce sedative effect. If you give increase the dose more, this will produce hypnosis. Diazepam with a large doses could be produce general anesthesia. If you prescribe toxic effect of diazepam, large doses, overdose of diazepam, this will lead to the coma. So we have depends on the dose, we are going to see the response. Relief anxiety, reduce sedative effect, reduce hypnosis, hypnotic effect, produce general anesthesia, and at the end coma. And the coma you can see here is like severe inhibition of the central nervous system. Okay, this slide here is considered like one of the most important slides in our presentation today. This slide summarizes drug information. All the drug we are going to use it as a group of medication also. So we are going to maybe cover the 3 group of medication. The first group will be benzodiazepine. The second group will be barbiturate, and we have others. For the others, we have non-benzodiazepine, hypnotics, we have Z drugs, then we have melatonin receptor agonist, then we have orexin receptor antagonist, then we have some antihistamine produce hypnotic effect or reduce insomnia. Then we have some antidepressant off-label to use for the anxiety. Starting with the first group of medication, as you can see here in this column here on the left side, we have benzodiazepine. On the list of benzodiazepine, it's like in order of like alphabetic order from A to Z. We have alprazolam, Xanax. We have diazepam, Valium, lorazepam, Ativan, clonazepam, chlordiazepoxide, temazepam, oxazepam, triazolam, midazolam, and flurazepam. Moving to the barbiturate drug list here, we have phenobarbital, methohexital, butalbital, pentobarbital, brimidone, amobarbital. Okay. Okay, what about other medication, other sedative, hypnotic, anxiolytic drugs? Regarding the Z drugs, and the Z drugs use it to induce sleeping. We have 3 types. We have another medication here. It could be like Eszopiclone. So the list for the Z drugs, we call this one Z drug because it starts with the Z. We have Zolpidem, we have Zaleplon, then we have Eszopiclone. So we have Zolpidem, Zopiclone, Eszopiclone, Zaleplon. Okay, regarding the melatonin receptor agonist, we have Ramelteon, or like melatonin as natural product. So we have Ramelteon like melatonin receptor agonist, or we have melatonin. Orexin receptor antagonist, we are going to explain that later in the slide. We have Belsambra, we have Suvorexant, and we have Limborexants. Orexin, Rexant, we have REX, we have REX here. So Suvorexant, orexin receptor antagonist, Belsambra, then we have Limborexant, the Devago medication. For antihistamine, you can see here off-label for insomnia. What that means for us when you say off-label, when you read the prescription writing, prescription information for as antihistamine, you don't see it the prescription writing approved by the FDA or for with the pharmacopoeia. We don't have it in the information leaflet. So the medication leaflet does not mention the use of this medication, but as a maybe side effect of this medication, antihistamine may relieve insomnia, may use to induce sleeping. So what we have here, we have diphenhydramine and the brand name Benadryl, then we have doxylamine. So two medication belong to the antihistamine, could be used for to relieve insomnia and induce sleeping, or as hypnotic medication, antihistamine, diphenhydramine, doxylamine. Moving to the next group of medication, the last group belong to the others here. We talk about others. As you can see here, we have antidepressant, and this one considered like off-label for anxiety and insomnia. We have trazodone, mirtazapine, doxyben. So three medication used for anxiety and insomnia. Trazodone, mirtazapine, doxyben. Only one medication belong to this list of medication. We have Buspirone, Buspar, and this medication used only for anxiety. So you can see here we have options. We have hypnotic Z drugs. We are going to speak about characteristic of this group. Z drugs, Zolpidem, Zaleplon, Zopiclone, Eszopiclone, and then we have Buspirone for anxiety with a highlight. That means this medication considered like one of the most important medication on the list here. This slide considered also important. Why? Because this slide considered like a question in the exam, national exam, international exam. We ask, okay, what is a medication? What is a drug of choice? First line medication for patients from general anxiety, generalized anxiety, drug of choice for anxiety in general. First line medication, we have escitalopram, we have paroxetine, we have sertraline, we have duloxetine, we have venlafaxine. So all these medications considered like first-line therapy. So for patients from generalized anxiety, we are speaking about SSRI. This group of medication considered like SSRI. Okay, this group of medication considered SSRI. Then we have two medication here, duloxetine, venlafaxine, belong to the SNRIs. So the question here, what is the first-line therapy for the patients from general anxiety? General anxiety disorder, escitalopram, paroxetine, sertraline, duloxetine, venlafaxine. This is the first line therapy. What about the second line therapy? So you can see here, benzodiazepine is considered like second line therapy, not the first line therapy. Benzodiazepine in general, Buspirone, amabramine, pregabalin. Amabramine belong to the TCA, tricyclic antidepressant medication. Pregabalin belong to the anti-seizure medication. Okay, speaking about the benzodiazepine, so we will start with the first group of medication that belong to the anxiolytic, hypnotic drugs, sedative medication. So we have benzodiazepine. Sometimes we abbreviate this one with the BZs, or sometimes with the BNZ. So benzodiazepine, we have generic brand name for the list of medication. Start with the alprazolam, diazepam, lorazepam, clonazepam, chlordiazepoxide, temazepam, oxazepam, triazolam, midazolam, florazepam. how this medication work, any like a brief introduction for this medication. The benzodiazepine is considered like the most widely used anxiolytic drugs, most widely used. So we use it a lot in the practice. But currently we replace it. This medication replaced the barbiturate for treatment of anxiety, treatment of insomnia. And we, for example, if you have two choice between the benzodiazepine and barbiturate, which one you are going to prescribe? We prefer to prescribe benzodiazepine because benzodiazepine considered like safe medication and more effective medication. So this is important issue here, topics. So when you have maybe the choice between benzodiazepine and phenobarbital or barbiturate, so benzodiazepine considered safe medication and effective medication. But we need to, with the highlight here, they said, please remember that benzodiazepine considered like benzodiazepine are not the best choice for anxiety or insomnia. For anxiety or insomnia, remember that we have SSRI, then we have SNRIs. So we have a group of medication could be used for the situation here. Okay, so here we speaking in this slide here we are going to focus on the mechanism of action, how this medication work. We have three group of medication as we discussed in the beginning. We have benzodiazepine, barbiturate, and then we have others. So in general, benzodiazepine and barbiturate mainly work on the receptor in our brain or in our central nervous system, and this receptor called GABA A in general. So GABA A, you can see it here. GABA A, we have the ligand-gated channels. This ligand-gated chloride channel, you can see the chloride channel in the middle here in the center, and we have subunit, alpha subunit, GABA. So the GABA receptor, we have alpha subunit. We have two alpha subunit, we have two beta subunit, then we have gamma, and you can see the chloride channel in the center here. Okay, they tried to remind us here with the abbreviation. It's very important abbreviation. They said alpha 1, if you activate alpha 1 in the central nervous system, if you activate this alpha 1 subunit, if you activate it, this will lead to the induced sleeping. If you activate alpha 1, with this will lead to the anterograde amnesia. We are going to speak about that later on. If you activate alpha 2, this will relieve anxiety. If you activate alpha 2, this will lead to the relaxed skeletal muscle. Here someone may ask, okay, that mean if you activate alpha 1, this will lead to the sleep and anterograde amnesia? Not at the same time. It depends on the dose used for the treatment. If you use low dose of benzodiazepine will activate alpha 1 and induce sleeping. Low dose will activate alpha 2 and induce relief anxiety. If you increase the dose, increasing the dose will affect alpha 1 and cause anterograde amnesia. Increasing the dose will activate alpha 2, relax skeletal muscle. So it depends on the dose, therapeutic dose or high dose. Okay, speaking about the effect, here in our body we have GABA. GABA as a mediator. So when we speak about acetylcholine, we have acetylcholine as a mediator. We have receptor for the acetylcholine. We have muscarinic receptor. We have nicotinic receptor. And the acetylcholine moving in the central nervous system, binding to this receptor, activate the receptor. The same situation apply. We have GABA moving in the central nervous system, GABA binding to the GABA receptor. We have GABA receptor here. And we have two sites for the GABA receptor. You can see it. GABA receptor, GABA mediator here, bind to the receptor. So when the GABA bind to the receptor in two different sites on the GABA, when the GABA mediators, GABA neuromediator bind to its receptor, the result will be open chloride channel and induce sleeping. So when you go to sleep, GABA receptor will be activated, allow chloride to enter the cell, make the inside the cell negatively charged, and induce inhibitory effect to the central nervous system, allow patient to sleep. So GABA is very important receptor to keep the circadian rhythm of sleep. Okay, so this is about the normal activity, normal brain activity for the GABA receptor here. Okay, here what we have the first group of medication. We are going to discuss it here. You can see we have benzodiazepine. Benzodiazepine bind to the distinctive site of the GABA, when benzodiazepine bind to its site, benzodiazepine, diazepam or lorazepam or midazolam bind to the site, specific site on the GABA, this will activate the receptor. This will activate the receptor. What happened there? So the receptor will start opening chloride channel and allow chloride to influx to enter the cells, inside the cells. You can see here, here we have outside the cells. We have outside the cells, and this is a cell membrane. So this is what we have here. This is outside. This is inside. Okay, so this will allow the chloride to enter the cells. When the chloride enters the cell, will produce hyperpolarization. And you can see here when the GABA binding to its receptor, so benzodiazepine bind to the GABA receptor, open chloride channel, and cause maybe allow chloride to enter the cell, more chloride to enter the cells. You can see the arrows here. We have more chloride entering the cell and induce hyperpolarization. So we are going to discuss what are the effects of benzodiazepine on the central nervous system and the brain later on. So here, how this medication work again. Benzodiazepine work in the unique style of mechanism of action. You can see it here. They said benzodiazepines increase the frequency of opening chloride channel. So the channel will be open, close, and allow chloride to enter the cell and cause hyperpolarization. Okay, moving to the barbiturate. Again, here in the slide we discuss the mechanism of action. So the first one we discussed it with you, how the benzodiazepine. The first one we discussed it with you, how the benzodiazepine work on the central nervous system. We have the concept there. Benzodiazepine increase frequency of opening chloride channel, and this will lead to the hyperpolarization. What happened with the barbiturate here? As you can see here, barbiturate, we have another side, different side, barbiturate binding to the GABA receptor. That's good. And this will lead to the open chloride channel, allow chloride to enter the cell. And you can see here we have more chloride influx enter the cell from outside, more chloride. Okay, so the result will be hyperpolarization. So you can see it here. We have hyperpolarization. Here we can discuss several concepts, but the main concept here to differentiate between barbiturate and benzodiazepine, you can see here they said barbiturate, the main mechanism of action, increasing duration of opening chloride channel. So if you compare between benzodiazepine and barbiturate, you can see here the barbiturate increase the duration of opening. The chloride channel will be opened and remain open, allow chloride to enter the cell, and the result will be hyperpolarization, relaxation, relief anxiety, could be coma, could be like unwanted effect, like respiratory suppression or cardiovascular suppression. Okay, again, regarding the barbiturate, I would like to mention that barbiturate not only work on distinctive site on the GABA receptor. If you prescribe barbiturate in large doses, the barbiturate will work as instead of GABA, and barbiturate will be binding to the GABA receptor side. The barbiturate will bind to its receptor here. Barbiturate will bind to the GABA receptor and activation here. So what else? Barbiturate, they found in several studies, barbiturate inhibit the glutamate receptor. So we have three actions. Number one, barbiturate binding to its receptor. Number two, barbiturate binding to the GABA receptor and the GABA site receptor. If you increase the dose more, the barbiturate binding to the glutamate receptor in the neurons and central nervous system. For this reason here, barbiturate considered like medication carry the risk of respiratory suppression, cardiovascular suppression, and risk of death with the overdose. Okay, this slide here, maybe summarize the information. We have the maybe the visual slide, the image, the picture that explain how benzodiazepine work. And this slide try to explain benzodiazepine target the GABA. Benzodiazepine target the GABA. You can see it here. The target for benzodiazepine action are GABA A receptor. This is the first concept. So it's not GABA B. So the target for benzodiazepine GABA A receptor, please remember that. Moving next, benzodiazepine bind to the distinct site on the of the GABA receptor. This will lead to the increased frequency of opening chloride channels, and the end result will be hyperpolarization of the neurons. So we are going to speak what happened next. This will produce relief anxiety. This will induce sleeping. This will reduce like skeletal muscle relaxation or anticonvulsant effect. So we have several effects coming from the benzodiazepine. So as you can see here, we discussed it already in the previous slide regarding alpha 1 and alpha 2. They said with the low doses, low dose will be from benzodiazepine will activate alpha subunit on GABA receptor. So alpha 2 subunit will be activated. Alpha 2 subunit will be activated on the GABA receptor, and this will reduce the anxiety relief. So low dose of benzodiazepine activate alpha 2 subunit, reduce anxiety. If you prescribe higher dose will activate alpha 1 on GABA A and induce sedative and hypnotic effect. Okay, benzodiazepine may introduce something called anterograde amnesia, and which will mean for us anterograde amnesia like temporary impairment of memory. Anterograde amnesia, temporary impairment of memory through activation of alpha 1 receptor. So the hypnosis, alpha 1 receptor, and anterograde amnesia, alpha 1 receptor. Alpha 1 receptor also engage in the anticonvulsant effect. Skeletal muscle relaxation related to that stimulation of alpha 2 receptor. So here we need to remember, if you prescribe low dose, the situation will be reduce anxiety. Increase the dose, this will lead to the sedative and hypnotic effect and skeletal muscle relaxation. Okay, this slide brings the classification of benzodiazepine according to the duration of action. We have another slide, for example, if you are interested of pharmacokinetic, the another slide will speak about the half-life of the medication, T half-life, and T half-life is totally different from the duration of action or the frequency of prescription. So we need to differentiate between half-life and duration of action. So for the clinical practice, they try to categorize the benzodiazepine in the 4 group here, but in general we have, as you can see, we have short, intermediate, we have long acting. We have another medication now considered like ultra short acting, approved by the FDA 2020. This medication Rimazolam, the Bivevo here, Rimazolam, and this medication duration of action for 30 minutes. We use it for the minor surgery, and the patient will be recovered and gain conscious after 30 minutes. Okay, for regarding, so this one here we need to remember the category. Number 1, ultra short acting, we have Rimazolam. Short acting, 1 hour, Triazolam, Midazolam. Intermediate acting, 6 to 8 hours, Alprazolam, Lorazepam, Temazepam. We have long acting, last for 8 to 14 hours. We have diazepam on this list. We have clonazepam, we have chlordiazepoxide, and we have flurazepam. Okay, so again, I'm going to repeat this category or classification of benzodiazepine according to the duration of action. You can see it here. We have ultra short acting, 30 minutes, short acting 1 hour, intermediate 6 to 8 hours, long acting 6 to 14. Rimazolam, the ultra short acting triazolam, midazolam, intermediate alprazolam, lorazepam, temazepam. Then we have long acting, we have clonazepam, diazepam, chlordiazepoxide, and flurazepam. Okay, regarding to the second column here on the right, we have in the maybe questions. This is the general. We have maybe some off-label use or some other uses, but this is the most popular use. Could be, for example, we can use, for example, for the, it's not on the list, so for the patients from alcohol withdrawal effect, we can reduce the diazepam or treat with the diazepam for the symptoms of withdrawal effect of alcohol. the maybe the major clinical therapeutic use of benzodiazepine, you can see here, we use it for anxiety disorder, anxiolytic to relieve anxiety. We use it for patients suffer from sleep disorder, difficult sleeping or difficult to maintain sleep. We use to induce amnesia during surgical procedure, during colonoscopy, for example. We use it for patients suffer from seizure. We use it for patients suffer from skeletal muscle spasm. So you can see it here, like we have several clinical effect and therapeutic use of benzodiazepine. Okay, speaking a little bit in more detail about therapeutic use of benzodiazepine, as you can see here, we use benzodiazepine for the anxiety, number one. Number two, for sleep disorder, amnesia, seizure, and muscle spasm, skeletal muscle spasm. Starting with the anxiety, as you can see, benzodiazepine are reserved for the severe anxiety. I like this one here. So we don't use it for that mean we use it only for the acute, for short-term treatment of anxiety. So please remember that here we use benzodiazepine for severe or acute anxiety and for short-term period. And the reason, because benzodiazepine may cause dependence, may cause addiction, may affect the memory. We don't prefer to use benzodiazepine as a first-line therapy for the anxiety. So please remember, benzodiazepine reserved for severe acute anxiety and due to the potential of addictive dependency, physical dependence, or like other maybe abuse or like tolerance. This medication used only for short period of time. Okay, number one. Number two, sleep disorders. If the patient suffers from difficulty falling asleep, okay, we need some medication to enhance sleeping, help the patient to maybe fall asleep. We are going to use some medication belong to the short acting. Start working after like 30 minutes to 1 hour short acting, effective in the individual who suffer from difficulty falling asleep. What about intermediate acting, like 6 hours to 8 hours? This medication considered like beneficial in patient experience frequent waking and having difficulty staying asleep. So if the patient suffer from difficulty maintain sleep, so this is the intermediate, go with that temazepam. If the patient suffer from difficulty by starting sleeping, falling asleep, triazepam like could be the best option here. What about long acting? Do you use long acting? They said it's rarely used. Long acting because we have remain effect. We don't prefer to use it. For example, if you use for example, lorazepam or diazepam to induce sleeping, and when you wake up in the morning, you are going to suffer from sedation effect, hangover, due to that drug accumulation in the human body. Okay, amnesia. So we discussed that. Number one, we discussed the anxiety. Second, we discussed the sleep disorder. Third one, amnesia. We have midazolam, for example. Midazolam considered also, so if you go to the previous slide, midazolam. Here we have midazolam short acting, like 1 hour. We use midazolam to induce and interrogate amnesia, and for short maybe general anesthesia, during general anesthesia, for short general anesthesia to provide sedation before surgery, during the colonoscopy, during the wisdom teeth extraction. We use midazolam or Xanax, alprazolam to reduce amnesia. When the patient leave the clinic after surgery, they will forget totally what happened during surgery. Okay, the next we have seizure. Clonazepam could be the medication for certain type of seizure, clonazepam. Then we have lorazepam, diazepam, and this medication is considered like used for the IV intravenous for the status epilepticus. This is emergency case. We have lorazepam and diazepam. If the patient suffers from skeletal muscle relax spasm, we can use diazepam for the treatment, and we cover that in the skeletal muscle relaxant lectures. Okay, in this slide here, we try to cover the aspect, the adverse drug reaction, ADR, adverse drug reaction, okay, and warning, or CI stands for contraindication. That means we don't allow to use this medication in some cases. Some warning and precaution: adverse drug reaction, unwanted effect might happen during the use of benzodiazepine. Number one, we have some facts here. They said all benzodiazepine cross placenta barrier and depress the central nervous system of the newborn. So for this reason here, we don't recommend to use benzodiazepine during pregnancy, because benzodiazepine cross placenta barrier, arrive to the brain of the baby, the newborn baby, and will suppress the brain of central nervous system of the newborn child. Nursing during lactation, we don't prefer to use it, because this medication cross the breast milk and produce the effect on the babies. This medication carry the risk of dependence with the high doses, so can develop the dependence, especially if you talk about high doses. So, or you can, when you use this medication for prolonged period of time, so dependence will happen after this two occasions. So the patient may suffer from dependence on the benzodiazepine if you use it like for prolonged period of time, more than weeks, 3, 4, 5 weeks of treatment, or if you use high doses of benzodiazepine, this will produce the dependence. So speaking about dependence, we have physical dependence, we have psychological dependency. Okay, again, we have an important issue here. When the patient develop dependence, that means it's not easy to stop this medication suddenly. For this reason, we have recommendation, stop this medication gradually, because if you stop this medication abruptly, the situation will cause withdrawal symptoms, and the patient may come to the hospital suffer from confusion, anxiety, agitation, restlessness, insomnia, tension, and in some cases we are going to see patients suffer from seizure in the emergency room. So you can see here we have okay, number one, for benzodiazepine, not recommended during pregnancy, not recommended during lactation. Benzodiazepine produce psychological, physical dependence. We recommend to stop this medication gradually because of the possibility of withdrawal symptom if you stop this medication suddenly. Okay, moving to the second column for the adverse drug reaction. This medication may cause drowsiness, may cause confusion. This medication may cause ataxia with the high doses, cognitive impairment. This is very important. Here we need to maybe warn the patient about the warning on the machine or driving the vehicle. It's very important to be careful about prescribing this medication to the patient, because there is a risk of car accident or the machine accident. If the patient suffers from liver disease, we need to use this medication cautiously, and sometimes we need to adjust the doses. And if you have severe liver disease, we don't recommend to use this medication. As you can see here, benzodiazepine in general activate GABA. Activating GABA mean inhibit the central nervous system. Okay, what happened with other medications? They said alcohol inhibit the central nervous system. We have other depressant for the central nervous system. So what happened if the patient take benzodiazepine and drink alcohol? The situation will be aggravate effect of inhibitory action on the central nervous system, and the patient may die from the overdose from benzodiazepine. We don't recommend to use the alcohol with the benzodiazepine because the risk of toxicity. Okay, benzodiazepine considered like less dangerous than older anxiolytic. Here we are speaking about barbiturate, especially about phenobarbital. So you can see here we talk. This is old anxiolytic hypnotic medication. So benzodiazepine in general considered like less dangerous than the barbiturate. Okay, so this number one. Another important things here, they said, okay, benzodiazepine is very rare to cause death. It's seldom to be lethal. As a result, a drug overdose is seldom lethal unless the central depressants such as alcohol, opioid are taken concurrently. So if you have overdose from benzodiazepine only, it's very, very rare to see a case of death from benzodiazepine. But what happens if the patient take benzodiazepine and opioid? Benzodiazepine, for example, diazepam, Valium, and fentanyl. Okay, so with the fentanyl and benzodiazepine, the result will be death. Okay, depression and death overdose. Okay, this slide here consider like life-saving slide. What that mean, life-saving slide? This slide present a medication that consider life-saving medication. Flumazenil, as you can see, is here available like IV flumazenil injection for intravenous only. Flumazenil consider like GABA receptor antagonist, and this flumazenil, this medication, reverse the effect of benzodiazepine. They will displace the benzodiazepine from the receptor. Okay, this is number one. So if the patients are from coma due to the overdose of benzodiazepine, this is a medication we use it that is considered like antidote. Okay, this number one. Number two, benzodiazepine could be administered to the patient dependent on the flumazenil could be prescribed to the patients from addiction on the diazepam. So if you prescribe this medication, flumazenil, so this one for the situation here, for the flumazenil, we use it for coma, and coma, we all agree, is considered like acute case. So acute case, or we can call this one like overdose. So what you are going to do if the patient come to the clinic, to the emergency room with the overdose of benzodiazepine, these patients are from coma, acute situation, we're going to prescribe IV flumazenil antidote to regain consciousness. Okay, this is for chronic, for acute treatment, acute case. So what happened if the patient already addicted on the benzodiazepine and the patient come to the clinic and you ask the patient, do you take benzodiazepine? And the patient said no. And if you prescribe for flumazenil to the chronic addicted person on diazepam, so you are going to trigger withdrawal symptoms here. So what happened here? The patient already addicted, already on the chronic use of benzodiazepine. So if you prescribe flumazenil, or if you inject flumazenil to this patient, this will displace, this will remove the benzodiazepine from the GABA and induce or trigger withdrawal symptoms here. And this may cause also like a seizure for the patient. This will conclude the information about benzodiazepine. We discussed the classification like ultra short acting, intermediate, long acting. We discussed the clinical use. We discussed the adverse drug reaction, uses in pregnancy and lactation. We discussed the adverse drug reaction. Then we have antidote if the patient come to the clinic or the emergency room suffer from coma due to the overdose or toxic dose from benzodiazepine. Okay, moving to the next group of medication used for anxiety. So benzodiazepine used for anxiety. What about other anxiolytic drugs? Medication used for anxiety. We have the first group of medication. As you can see it here, we have SSRI, we have escitalopram, paroxetine. Then we have SNRI, venlafaxine, and duloxetine. Again, I will repeat the slide here. The first group, we discussed it with you, like benzodiazepine. The second group of medication for anxiety and considered like anxiolytic agent. As you can see here, we have SSRI, escitalopram, paroxetine, for this example here. And SSRI, according to the references and encyclopedia or pharmacopoeia, you can see here consider first-line agent for chronic anxiety disorder. This will bring us to another topic. So if you have patients from acute anxiety, so we can go with the benzodiazepine. So for the acute anxiety, what about the chronic anxiety? So if you have patients from chronic anxiety, the drug of choice will be SSRI, escitalopram, paroxetine. So for general anxiety, SSRI. We have escitalopram and paroxetine for chronic treatment. What about acute? We start with the benzodiazepine. Another group of medication for the situation for anxiety, anxiolytic, we have SNRI, we have venlafaxine and duloxetine. Okay, the situation here, very important topic to be covered here with the SNRI and SSRI. Okay, I would like to explain an important topic here or important concept uh, by using the SNRI or SNRI or SSRI. This will take time for antidepressant medication for both of them. Like for example, if you prescribe escitalopram to the patient with the dark blue curve here, you can see here we the patient need like at least like 2 weeks time for the escitalopram. You need the patient need like two to or more. I will maybe do it in different color here for us. So you can see here the citalopram start working after 2 weeks, for example, and start seeing effect after 2 to 4 weeks time with the citalopram. So if the patient come to the clinic and you prescribe citalopram to your patient, the effect will start after like 15 days or like 20 days or 1 month sometimes. So some textbooks they said that to start effect they need 2 to 12 weeks to see the effect of antidepressant SSRI or SNRIs. 2 to 12 weeks, this long time, and the patient maybe or the relative cannot wait for this long time or period of time. So what happened in the practice normally when you prescribe escitalopram to the patient, we can maybe combine the prescription with the lorazepam. Lorazepam start working quickly, and you can see here like during maybe the first day or the second day of the treatment, the first week of the treatment, you can see the effect of the lorazepam. And when the we can remain using diazepam for 1 to 2 weeks time, and when the escitalopram start effect, we stop the lorazepam medication. So here what we have, they said we use it alone, this medication, or we can prescribe it with a combination with the benzodiazepine for the first week of the treatment. You can see it here, we use it in the first week of the treatment. After 4 to 6 weeks, when the antidepressant begin to produce the anxiolytic effect, benzodiazepine can be tapered. So we can remove the benzodiazepine from treatment. So when you have patients from chronic anxiety and we need to see a fast effect or like quick effect on the patient, we prescribe escitalopram, but escitalopram need time to produce its activities, 2 weeks time or like 3 weeks or like more. So in this case, we combine escitalopram with the lorazepam, and lorazepam has a rapid onset of action, and you can see the effect quickly here, the green curve there, and produce the effect. Okay, one of the most important medication used for treatment, for chronic treatment of general anxiety, we have Buspirone. Buspirone, you consider like useful medication for general anxiety disorder. So Buspirone considered like the most popular medication for chronic treatment of general anxiety disorder. Its efficacy is like similar to the benzodiazepine. It has slow onset of action, as you can see here. It's need time to see the effect for the. So when you prescribe it, maybe we need 1 week or 2 weeks time to see the effect. This medication is not effective as a short term. So if the patients come to the clinic suffer from, or the hospital suffer from acute anxiety, we cannot use this medication because this medication works slowly, takes sometime week or two. So what happened here? So for this reason here, we don't use it for acute treatment. So please remember, this medication need time to produce the action. Okay, moving to the second column, how this medication work for Buspirone. Several resources, medical literature, they mentioned that Buspirone, Buspar, they said Buspirone considered like partial agonist for the serotonin receptor 5-HT1A. So this is how this medication work. Affect the partial agonist for serotonin receptor 1A. Less side effect compared with diazepam. Less likely to cause dependency. Do not potentiate the central nervous system depression with alcohol. So the situation here, if you have alcoholic patient come to the clinic and this patient suffer from anxiety, Buspirone drug of choice, because there is no drug interaction between alcohol and the Buspirone, but we have interaction between Buspirone, between alcohol and benzodiazepine. So the question now, which of the following medication we can use for patients from alcohol and anxiety, Buspirone or benzodiazepine? So the correct answer will be Buspirone. which of these medication we use it for patients suffer from anxiety, and this medication does not carry the risk of dependency. Okay, the correct answer will be Buspirone. Okay, the third group of medication here we have barbiturate. As you can see here, barbiturate, we have from the name barbiturates, we have a group of medication belong to the barbiturates, and the prototype we have phenobarbital. Barbiturate were primarily used for the treatment for patients suffer from anxiety, suffer from insomnia, but barbiturate largely replaced by benzodiazepine. So barbiturate have been largely replaced by benzodiazepine due to the risk of tolerance, dependence, and withdrawal symptoms. So the patient may suffer from severe withdrawal symptom. It's more severe than the benzodiazepine, for example. So there is a risk of tolerance, physical dependence, and severe withdrawal symptoms. For this reason here, we replace barbiturate in clinical use with the benzodiazepine. So benzodiazepine considered effective medication, safer medication compared with the barbiturate. Okay, how the barbiturate work? We have the slide in the beginning. I recommend you to go to the first slide in the lectures. But this text here explains simply how the barbiturate work. As you can see here, number one, they mentioned there the barbiturate potentiate the GABA action on the chloride channel, and barbiturate prolonging the duration of chloride channel opening. Open the chloride channel, allow chloride to enter the cell, cause hyperpolarization. Number one. Number two, they said with the barbiturate carry the effect of blocking the excitatory glutamate receptor. So not only affecting the GABA receptor, but also barbiturate in the normal or high doses, overdose, may inhibit the glutamate receptor. Okay, again, the drug list here for barbiturate, we needed to remember this drug list is very important. Phenobarbital, methohexital, then we have butalbital, phenobarbital, brimidone, or amobarbital. Moving to the clinical use, I will go back again to remind you of the list. Barbiturate, phenobarbital, butalbital, pentobarbital, then we have bromidone, amobarbital. Regarding the clinical use of barbiturate, number one, patients suffer from seizure, barbiturate. Patients suffer from status epilepticus. Here it's like emergency treatment here, IV. Okay, patients suffer from patient maybe or neonatal suffer from withdrawal effect of, for example, opioid or something else from when the mother pregnant woman use opioid. We have patients suffer from convulsions, so we have it for neonatal withdrawal effect. Patients suffer from insomnia, difficulty sleeping, difficulty to maintain sleep. We use it like post-operative anxiety and general anesthesia IV. So you can see the clinical use of medication here, but as you mentioned in the beginning, barbiturates have been replaced by benzodiazepine for the clinical practice. Okay, according to the article published in the Stat Barrels, here you can see the link. This one published in NIH, National Institute of Health. This one shows us the clinical use of phenobarbital. We use phenobarbital for epilepsy. We use phenobarbital for patients from refractory status epilepticus. What that mean for us? So if you use diazepam for patients from status epilepticus, but the patient does not respond to the diazepam, this is the alternative here. So we use it for patient does not respond to the other medication for status epilepticus. Severe traumatic brain injury, IV. You can see it here. Concern about the safety profile. Here, safety profile is very important. This medication, if you prescribe it overdose from phenobarbital, the result will be suppress respiratory center, suppress cardiovascular center, and death. There is no recovery from this one. We have recovery, but we don't have antidote. We have recovery if you maybe intervene quickly, bring the patient quickly to the hospital, to the emergency room, and we take maybe the procedure to rescue the patient. Okay, butalbital here. Butalbital, according to the textbook and according to the articles, They said butalbital combined with the acetaminophen, combined with the Tylenol, combined with the caffeine. So you can see here acetaminophen, butalbital, caffeine, all these medication together, and this medication used for headache disorders. And this combination approved by the FDA for tension type headaches. Okay. Okay, here we have, as you can see on the Google search, butalbital, acetaminophen, caffeine. You can see it here like available as tablets, and this medication approved for treatment of headache. You can see the combination here in one tablet, butalbital, acetaminophen, caffeine, and we use this medication for patients suffering from headache disorder. Okay, this one here from the website about barbiturate from the NIH. I will minimize a little bit the page for you. Okay, you can see from National Library of Medicine, to give the credit to this website. And then we have the barbiturate, talking about barbiturate here. Barbiturate approved by the US FDA for clinical use for phenobarbital, barbiturate, pentobarbital. Then we go down to the indication of use. For example, we already covered all these with you. For example, we discussed the primary use of thiabental, for example, for the general anesthesia. Then we have other medications such as phenobarbital for the epilepsy. Okay, this slide here show you the newly published topics in NIH stat barrels about the barbiturate, published in January 29, 2014. As you can see here, barbiturate approved by the FDA for clinical use include phenobarbital, methotrexate, butalbital, phenobarbital, brimidone for the epilepsy, amobarbital. So if you go to the indication here, we have phenobarbital here, then we have butalbital. Butalbital here, we talk about the combination of treatment, acetaminophen, caffeine, and butalbital. Then we have bromidone for the epilepsy disorders. So we have maybe the combination treatment and the clinical use for several medication according to the individual drugs. Again, this slide here reminds us with the classification of benzodiazepine. If you go back to the previous slide, benzodiazepine, we have ultra short acting, we have short acting, intermediate, long acting. The same will be applied for the barbiturate classification of barbiturate. We have ultra short acting, intermediate, long acting. Regarding ultra short acting, we have two medication. We have highlight for one medication, thiabental. This medication, when you inject this medication IV, this medication duration of action 15 minutes or 30 minutes. Some textbook they say 20 minutes. So very short, ultra short duration of action. Followed by pentobarbital, secobarbital, considered like short acting. Intermediate acting, butalbital, long acting, phenobarbital, brimidone. So I will repeat what we have here. Regarding classification of barbiturate, we have four main groups. Ultra short acting, we have thiabental, duration of action 15 to 30 minutes. Short acting barbiturate, we have pentobarbital, secobarbital, and duration of action like 1 hour. Intermediate acting, amobarbital, butalbital. For long acting, more than day, could be 2 to 3 days, phenobarbital, brimidone. This slide here presents the effect of barbiturate according to the dose. They said if you prescribe lower dose to the patient, and you escalate the dose, what happened? If you prescribe lower dose, this medication will cause sedation. If you escalate the dose, if you increase the dose, this medication will cause hypnosis. If you escalate the dose more, the situation will be general anesthesia. If you give overdose, toxic dose, this will lead to the coma, and this coma could lead to the respiratory suppression and death. So you can see here, according to the dose, we have different effects. We start from sedation, hypnosis, general anesthesia, moving to the coma, and death due to the respiratory suppression. So here, barbiturate action depends on the dose-dependent effect. Start from sedation, hypnosis, general anesthesia, coma, death, and respiratory depression. Okay, what happened there we need to remember this medication here, very important properties for the barbiturates. They try to remind us here They try to remind us with the important topics. Okay, very important concept here for barbiturate. Barbiturate cross placenta barrier and it's not allowed to use during pregnancy due to the risk of depression, newborn brain depression. So there is a risk of depression in the newborn baby. If the patients are from pain disorders or like pain, and this medication we don't use barbiturate for the pain relief or painkiller. So barbiturates do not have any analgesic effect. Again, we have some side effect regarding the adverse drug reaction, drowsiness, impaired concentration, impaired mental impairment, and psychomotor impairment. It's okay, that's fine. But the important issue here with maybe associated with the barbiturate, we need you to focus on and be alert for that. So what we have here, they said barbiturate induced cytochrome B450, and this will maybe bring the risk of drug-drug interaction. For example, when you use barbiturate with a warfarin, and there is a risk of the, for example, glotting effect or like myocardial infarction. So we don't recommend to use phenobarbital and warfarin because phenobarbital accelerate metabolism of warfarin and decrease concentration of warfarin, and this will lead to the risk of glotting or myocardial infarction or stroke. This is number one. So please remember, barbiturate accelerate metabolism, especially the CYP or cytochrome B450. Moving to the dependence and tolerance, the patient maybe take the barbiturate for long period of time, may suffer from dependence and addiction. For this reason here, we don't recommend to stop this medication abruptly, because if you stop this medication abruptly, the situation will be producing withdrawal symptoms or withdrawal effect, and the patient may suffer from tremor, anxiety, weaknesses, restlessness, nausea, seizure, delirium, and could lead to the cardiac arrest. So you can see here we have some maybe characteristic or disadvantage compared with the benzodiazepine. So benzodiazepine does not induce cytochrome, barbiturate induce cytochrome, and there's risk of drug-drug interaction. We have severe withdrawal effect compared with a benzodiazepine. Okay. So what we have here regarding the overdose of barbiturate may lead to the death due to the severe respiratory and central cardiovascular depression. So the barbiturate inhibit respiratory center, barbiturate inhibit the cardiovascular center in the brain, and this will lead to the death. The question now, do we have antidote for the treatment? No, we don't have antidote for currently we don't have antidote for the overdose toxicity from barbiturate. The treatment will be supportive measures, supportive procedures to rescue the patient. If the patient arrives early to the clinic emergency room, we can practice gastric decontamination. We can maybe follow the manipulation of the pH of urine. And for more details how to rescue patient with the toxic effect overdose of barbiturate, I refer you to the toxicology course to maybe how to manage patient with the toxic effect of barbiturate. Okay, in this slide we have practice question. We have a 40-year-old woman experience acute episodes of intense anxiety combined by significant physical symptoms such as hyperventilation, tachycardia, sweating. If diagnosed with a panic disorder, if the patient diagnosed with a panic disorder, which medication would be the most appropriate to prescribe? We have alprazolam, Eszopiclone, flurazepam, propranolol, Ramelteon. So the best way to approach this question to start with something not related to the topics. So for example, I will start with looking on the Ramelteon, for example here. Okay, Ramelteon belong to the melatonin agonist. Ramelteon belong to the melatonin agonist, and this used to induce sleep. It's not this medication. Propranolol, it's not for the acute episodes of anxiety. Propranolol used normally for anxiety, but for the chronic treatment, okay, it's not propranolol. What about flurazepam? Flurazepam, long acting, not for acute, take times, need time to produce effect, not flurazepam. What about Eszopiclone? Not Eszopiclone, because Eszopiclone considered like hypnotic agent, belong to the Z drug. Alprazolam, yes, I will go with alprazolam. Alprazolam considered like short intermediate acting medication, and alprazolam used for acute treatment. So I would like to share with you the link here. Okay, so maximize the page a little bit to show you what we have. Xanax, alprazolam, you can see it here, tablets, oral use. I'm not going to discuss the warning with you now here, but if you scroll down, indication for alprazolam, Xanax, acute treatment of general anxiety disorder, acute treatment for general anxiety disorder, acute. Number 2, treatment of panic disorder, with or without agoraphobia. So you can see here we have it for general acute treatment of general anxiety and for the treatment of panic disorders, and this medication considered like the drug treatment for the situation. Do we have another medication for panic disorders? We need to cover this here. Yes, we have another medication. I will cover, maybe discuss it with you. Not only alprazolam, we have another medication. If you click on the link here, another medication. Yes, we have fluoxetine, Prozac. So if you maybe maximize the indication here, we talk about Prozac, fluoxetine. So indication. Okay, so we use it for the fluoxetine for depression. Fluoxetine we use it for obsessive disorders, treatment of bulimia. You can see number 4 here. We can use it for acute treatment for panic disorder. So for the paroxetine Prozac here, so we can we add another medication? Yes, we can add another medication to the list. We need you to remember we have alprazolam and then we have Prozac here. So we can use Prozac as another option for the patient. Any other medication for the panic disorders? Okay, so what we have here, clonazepam. So if you scroll down for clonazepam here, clonazepam for clinical indication, you can see the panic disorders. So for the clonazepam, also another option to use for the, so the Prozac, this is one option. So we have one option here, one option alprazolam, another option Prozac, fluoxetine. This is another option. The third option will be, so what do you think the first option here? I will go back again. Clonazepam. Okay, we can add here clonazepam. So for panic disorder, we have at least in the for the clinical use alprazolam, clonazepam, fluoxetine, or Prozac. Okay. Okay, regarding group number 4, here we have other hypnotic agents. We have Zolpidem, Zaleplon, Eszopiclone, Melatonin receptor agonist, antihistamine, antidepressant, and suvorexant, or considered like orexin antagonist. For the melatonin receptor agonist, we have Ramelteon and Tasimelton. Antihistamine, we have diphenhydramine, and you can see the brand name here, diphenhydramine for the Benadryl. And this medication used for allergy, but as a side effect of this medication may cause drowsiness and induce sleeping. Hydroxyzine, then we have doxylamine. Antidepressant, list of medication considered like hypnotic. One of these medication, doxypen. So we need here to differentiate between the antidepressant used for the hypnotic induced sleeping and antidepressant used for general anxiety. And if you go back a little bit on the previous slide, you can remember that for anxiety we use escitalopram or paroxetine or duloxetine or venlafaxine. For the hypnotic sleeping, we have doxypen as antidepressant here. Okay, briefly discussion about the Zolpidem. Zolpidem is considered like hypnotic drugs, but Zolpidem considered like non-benzodiazepine medication. It's not structure related to the benzodiazepine, as you can see here. Zolpidem bind to the GABA A receptor, but we have some characteristic here. They said benzodiazepine has no anticonvulsant effect. Zolpidem has no muscle relaxant effect or like other withdrawal effect. So you can see here we have some advantages of Zolpidem. So if you prescribe Zolpidem to patients from insomnia, this medication, like a characteristic, it's like has no anticonvulsant effect, no muscle relaxant effect, and less the withdrawal effect and little the tolerance event due to the prolonged use. So as you can see here, Zolpidem has some characteristic here, structure related to the benzodiazepine, number one. Number two, bind to the GABA A receptor. Number three, this medication has no anticonvulsant properties. This medication has no muscle relaxant properties. This medication has few withdrawal effect and little tolerance. This medication may cause interrograde amnesia, this next morning impairment. Patient may suffer from sleepwalking or sleep driving, or performed some other activity while he is not fully awake. So this could be considered like important side effect if someone suffers from sleepwalking or sleep driving, could be involved in accident, for example. Okay, as a comparison between Zolpidem and Zaleplon, so for the Zaleplon Sonata, as you can see here, for the Sonata, considered like short-acting medication. This medication use considered like rapid onset of action and short duration of action. Zaleplon Sonata, rapid onset of action, short duration. We use it for patients suffer from difficulty to start sleeping, to falling asleep. If you suffer from difficulty falling asleep, that this medication will be the good option. Zaleplon Sonata, short acting, rapid onset of action. This medication less less next day drowsiness and dependence. What about Zolpidem, Ambien? Zolpidem, this medication used for patients suffer from difficulty falling asleep or patients suffer from difficulty of maintaining sleep. So the patient wake up several times during the night. This is a medication. This medication considered Zolpidem, Ambien, considered like long duration of action, several hours, like 4 to 6 hours. Here we have less than 3 hours. So for the Zolpidem carry the risk of high risk of drowsiness and dependence for the with the higher doses here. So please remember we have Zolpidem, Zaleplon, rapid onset of action, short duration of action. We use it only to help patient to start sleeping. Speaking about Zolpidem, okay, help patient to fall asleep and maintain sleep. So we have some patient to wake up during the night several times. This medication, Zolpidem, long-acting medication, okay, maybe provide more stability of sleep during the night. Okay, moving to the next group of medication used for induce hypnosis or facilitate sleeping. We have melatonin receptor agonist, Ramelteon, and we have tasimelton, selective agonist for melatonin melatonin 1 and melatonin 2 receptor. This melatonin hormone secreted by the pineal gland and help maintain circadian rhythm and underlying the normal sleep-wake cycle. So we have sleep-wake cycle, and this hormone help us to regulate this cycle, normal sleep-wake cycle. So we have melatonin maybe produced during the night to help us fall on sleep. So if you stimulate the receptor, melatonin stimulate the receptor M1 and M2 receptor here. Stimulation M1 M2 receptor by Ramelteon or tasimelton thought to be induced and promotes sleeping, and this medication could be used for the treatment of insomnia. Ramelteon and tasimelton, there is no evidence of the dependence or withdrawal occurred during the treatment with these two medication. This medication can't be used for the long term because there's no risk of dependence or withdrawal effect. So melatonin receptor agonist, Ramelteon, and tasimilton, agonist for the selective agonist for melatonin receptor 1 and 2, and this will help to maintain circadian rhythm of sleeping. This medication stimulate the receptor melatonin 1 and 2 receptor, the less risk of dependence and withdrawal, and this medication could be prescribed like long-term uses or long-term period. Okay, regarding the another group of medication could be used as adjunctive therapy. We have antihistamine, we have diphenhydramine, we have hydroxyzine, doxylamine. This medication available as mild to treat mild insomnia. So if the patients are from mild insomnia, we can use this medication, and this is as adverse effect or side effect of this anti-allergic medication, diphenhydramine, Benadryl, or doxylamine as anti-muscarinic medication. This medication may carry the effect of anticholinergic. The patient may suffer from blurred vision, dry mouth, and so and like urinary retention, for example. This medication less useful than benzodiazepine and non-benzodiazepine like Z-drug, for example. Okay, so this medication less effective and available over the counter, so we can buy it from the supermarket without prescription. Then we discuss the antidepressant. We have doxyben, and we recommend you to refer you to the antidepressant lecture. The last one here on the list, we have cefuroxant. Cefuroxant, we have Belsomra. This is considered like a new medication. Belsomra, cefuroxant, considered like antagonist of the orexin receptor. And for the maybe clarification, orexin considered like neuropeptide that promote wakefulness. So orexin involved in the alertness, and cefuroxant inhibit the orexin receptor and help to or could be used for patients suffering from insomnia. So we have list of medication could be used for anxiety, could be used for insomnia, could be used for the sedative effect. This is the last slide for our lecture for today. The purpose of this slide only like simple comparison between the benzodiazepine and barbiturate classification. As you can see, for both of them we have ultra short acting, intermediate, long acting. For example, Remazolam for the benzodiazepine, ultra short acting, Thiabental for barbiturate, short acting triazolam, midazolam, benzodiazepine, Secobarbital, Pentobarbital for the Phenobarbital. Then we have intermediate acting 6 to 8 hour. We have Xanax, Alprazolam, Ativan, Lorazepam, Temazepam. If you look on the intermediate, we have Butalbital, and we discussed that with for the combination treatment with acetaminophen and caffeine to use for the headache disorders. Then we have long-acting phenobarbital, Bromidone. For the benzodiazepine, we have diazepam, flurazepam, chlordiazepoxide, and we have clonazepam. Okay, as a summary and recap for our lecture for today, we discuss sedative, hypnotic, anxiolytic, and then we have the discussion about the degree of anxiety, normal person activity, sedation, hypnosis, general anesthesia, and coma. We have it like stairs, and we discuss it with you what happened on the brain with the anxiety, overactivity of the brain, normal activity with the like equilibrium between the normal activity of the brain. Then we have less activity, more inhibitory effect, moving from sedative, hypnosis, general anesthesia, and coma. Then we discuss the three main group of medication used as sedative, hypnotic, anxiolytic. We have benzodiazepine, barbiturate, and other medication. For the other medication, we discussed with you the non-benzodiazepine Z drugs used as hypnotic. We have Zolpidem, Eszopiclone, Zaleplon, and then we bring the melatonin agonists. We have Ramelteon, Then we have orexin receptor antagonist. We have Belsomra. We discussed off-label use of antihistamine as a treatment for insomnia. We have diphenhydramine, Benadryl. We have some antidepressants as for insomnia and induced sleeping. We have doxyben, buspirone used for anxiety. So here we need to remember which one used for anxiety, which one used for the insomnia. Again, for the medication used for anxiety, first drug medication will be SSRI or SNRI. The medication example for first-line therapy is citalopram, paroxetine, sertraline, duloxetine, venlafaxine. Medication related to the second-line therapy. So the first line is not benzodiazepine. The first line for anxiety is not barbiturate. So the first line for the anxiety will be escitalopram, paroxetine, sertraline, duloxetine, venlafaxine. Second line could be benzodiazepine, could be buspirone, or could be imipramine or pregabalin. We discussed how this medication work, and we discussed the GABA receptor, where is the location or the site of location of benzodiazepine and non-benzodiazepine, barbiturate, how this medication work. For example, which of these medication increase frequency of opening GABA chloride channel, which of these medication increase duration of opening chloride channel. We discussed the clinical use of this medication. Do we have antidote? For example, benzodiazepine, we have antidote. The antidote for benzodiazepine called Flumazenil. We don't have antidote for phenobarbital or barbiturate. If the patient takes toxic dose of barbiturate and does not arrive to the hospital on time, the patient will die or from the respiratory suppression and cardiovascular center suppression. Okay, at the end of this lecture, thank you so much for watching and have a great day, everyone.